All right, the next paper is Laparoscopic Roux-En-Y gastric bypass reduces elevated glucose 6-phosphate dehydrogenase activity in morbidly obese diabetic patients. And the presenter is Dr. Andrew Schneider from University of South Alabama College of Medicine. And just so you all know, Dr. Schneider is actually an undergraduate college student, so he deserves a round of applause just for that.
So, Mr. Schneider. My name's Andrew. I'm from the University of South Alabama College of Medicine. I had the great opportunity to work with quite a few people there on G6PD. First, no financial disclosures. However, we did receive a very generous research grant award from SAGES in 2010 to fund this project, and without them, this would not have been possible. So what is G6PD? It functions in the body. It's very important, and basically what it does is it reduces NADP to NADPH. And the body then uses NADPH to fuel fatty acid synthesis. So how does that relate to diabetes? Gupte in 2009, one of the researchers on our project, and Park in 2005 found high G6PD levels in the hepatocytes and adipocytes of Zucker diabetic and obese rats. Park was actually able to use siRNA knockdown on G6PD activity and saw decreased lipid accumulation. This is a good graph pretty much outlining all the research that has been done in the past decade on G6PD. And what we found is that obesity seems to correlate with increased G6PD levels. And what that means is as G6PD increases, we found increased adipogenesis, increased lipogenesis, and increased triglycerides and free fatty acids. And this causes two things. First, it leads to adipocytokine activation. We see increased tumor necrosis factor, increased resistin, along with decreased adiponectin. At the same time, we see hyperlipidemia, lipid toxicity, and eventual insulin resistance. As the resistance increases, we see decreased insulin signaling and decreased glucose uptake. And this insulin signaling and glucose uptake is made even worse by the increase in oxidative stress. So taking all this in, we decided to formulate a hypothesis on all the animal studies and really incorporate one of the first human studies on G6PD. So we decided that G6PD activity in obese type 2 diabetic patients is higher than the obese non-diabetic patients, and decreases in G6PD activity levels after surgery would be a mechanism of improved diabetes control. So we took our patients and put them into two separate groups based on whether they were diabetic or non-diabetic. Of course, we only enrolled type 2 diabetics, and we placed them into their groups based on their hemoglobin A1C. Here's what we found. You can see here we have G6PD activity in red blood cells between the non-diabetic and diabetic group, and we found significantly higher G6PD activity in the diabetic group compared to the non-diabetic. During surgery, we took a liver sample, and we also found that the diabetic group had significantly higher G6PD activity compared to the non-diabetic group in the liver as well. We took all of our patients and plotted G6PD activity in the liver against the glucose, their fasting glucose levels before surgery, and we found that as G6PD activity increases, so does fasting glucose. A nice positive correlation. After surgery, instead of decreases, we actually found an increase in activity amongst both groups. You can see here in the red blood cells of the non-diabetics, pre-op, 1 week, significantly higher, and then by 6 week and 12 week, just a very, very slow, not statistically significant decline. In our diabetics, we saw the same thing, an increase at 1 week and 6 week, but by 12 weeks, they seem to have come down almost to the preoperative level. So in summary, I can say that the G6PD levels are significantly higher in diabetics compared to non-diabetics. Their activity correlated with the severity of diabetes, and G6PD activity increases after laparoscopic Roux-En-Y gastric bypass. Conclusion, the increased levels of G6PD in the obese diabetics suggest there is an association, possibly a cause and effect between G6PD activity and type 2 diabetes. And the early increases in G6PD activity after laparoscopic Roux-En-Y gastric bypass does not support our hypothesis that reduction in those levels is a mechanism of improvement in diabetes. I could probably answer some of the biochemical questions, but I'm going to invite Dr. Richards up here to answer the surgical questions. He was the PI of the project and is the chief of surgery at USA.
Nicely presented, Mr. Schneider. Questions for Dr. Richards? I'll start out with a question. So, are we sure that elevated G6PD, or your hypothesis was that G6PD elevation leads to type 2 diabetes, and if it comes down, diabetes improves? Or does diabetes actually influence G6PD? So is it a chicken or the egg phenomenon?
That's the question. So in Andrew's presentation, we showed previously in animal models that you can knock out G6PD using this siRNA knockout. So you can decrease G6PD activity, and that reduces the amount of lipid accumulation and improves insulin sensitivity. So there are some suggestions in animal studies that indeed it's cause and effect, that G6PD is driving the type 2 diabetes. We have some studies in humans, again, using some medications that seem to inhibit G6PD that, again, improve insulin sensitivity and are very tempting to suggest that G6PD is the driver in many of these obese subjects. It's not the total driver, but it's interesting just to think about it, that G6PD may be driving some of our morbidly obese patients into this diabetic insulin resistance type 2 diabetes.
Thank you. Other questions? Do you know what happens to the G6PD levels in patients who undergo adjustable bands?
No, we don't. That's going to be some other projects, and we also have to study the G6PD levels in some lean subjects before and after surgery. So we've got a lot more work to do, and I'm trying to talk Andrew into spending a little bit more time this summer doing this work. Thanks for the opportunity to have us present.